Thank you. And of course, it's a very, very big topic. It's hard to cover very much in 45 minutes. Really, mostly going to focus just on pituitary problems. SIADH and diabetes insipidus, I think we'll have to save for another day. So I did prepare some questions, so I'm going to have some audience participation to keep you engaged and hopefully to make it more interesting. So when we think of people with pituitary or hypothalamic disorders, we think about three concepts. One, is there some sort of big old mass there? And that might be indicated by the patients complaining of headache or trouble with their vision. We think, is the pituitary producing too much of something, which might produce a syndrome, for example, hyperprolactinemia, acromegaly, Cushing syndrome, or is there some evidence for a hormone deficiency? So those are the three things that you're sort of thinking about when you're thinking about diseases in the hypothalamus and pituitary. So the first case is a 46-year-old woman with fatigue, weakness, irregular menses, and acne. She was found to have osteopenia with a DEXA scan, a BMD of minus 2.1. Her history had been unremarkable. She was 64 inches tall. She weighed 130 pounds. Her blood pressure was slightly elevated. She had some redness in her face and some proximal muscle weakness. And her 24-hour urinary free cortisol excretion was at the upper limit of normal, 52 micrograms. The baseline cortisol in the morning was within the normal range at 18, but was 17 the following morning after she was given 1 milligram of dexamethasone. The next test we did was the level of ACTH, which was 8 picograms per mil, with normal being only 10 to 90. So we did have another discussion of Cushing, so I'm not going to discuss Cushing syndrome in great extensiveness, but I did want to just include one talk about it. So what is the most likely site of the disorder in this woman who causing Cushing syndrome? So pituitary gland, pancreas, hypothalamus, adrenals, and lung. Well, that's right. So this is the Cushing syndrome due to an adrenal adenoma, and the clue is that the patient has a very low level of ACTH, which, just like hyperthyroidism, will turn off the TSH. Cortisol production produced by a tumor from the adrenals turns off ACTH, and it can be very subtle. Unlike the pituitary Cushing's, which can be a very flagrant disease, cortisol-producing tumors in the adrenal can be subtle. So you can see that this is the normal range of urinary free cortisol, and here are the people, and you can see that more than half of them have a urinary free cortisol in the normal range. So the Cushing syndrome of adrenal adenomas is much more subtle. Okay, so you got that. So the next case is a 52-year-old woman who she presents with several months of headache. She had been otherwise healthy and she takes no medicines. Her menses stopped at age 44. You find a left superior temporal visual field deficit. Endocrine testing revealed a low free T4 and normal levels of TSH, IGF-1, and alpha subunit, LH, FSH, and an appropriate rise in cortisol after cortrosine stimulation. The prolactin level was 85 nanograms per mil, and normal was less than 20. What's the next step in her management? Replace thyroxine, start cabergoline treatment, repeat the prolactin and measure macroprolactin, refer her to a neurosurgeon, or perform an insulin tolerance test. So, when you have a prolactin-producing pituitary tumor, and it's a large tumor, remember this lady had So when you have I didn't give you the MRI result. When you have a very large tumor, the tumor is going to produce prolactin in proportion to the size. So in large tumors, the prolactin level is going to be quite high. The bigger the tumor, the higher the prolactin level. On the other hand, if you have a microadenoma, the levels are usually much lower than with a macroprolactinoma, and they can range maybe from 50 or 60 nanograms per ml up to several hundred nanograms per ml. So when the tumor is large and the prolactin level is just slightly elevated, then the treatment is neurosurgical, because it's very unlikely to be a prolactinoma. On the other hand, when the tumor is small, then the prolactin level is variable, but it's usually more than 50 or 75 nanograms per ml. So I should have told you here that the tumor was large, and if the tumor was large, then I would have referred her to a neurosurgeon. On the other hand, if the tumor was small, then I would have treated with cabergoline. Now, you might have suspected that the tumor was large because she already had evidence for a field cut. So patients who have a microadenoma almost never have a visual field defect because the tumor is intracellular. So even though I made a blunder here and didn't include the MRI findings, you might have suspected that it was a macroadenoma based on the field defect, and would have recognized from what I told you just before that the prolactin level was too low for it to be a prolactinoma, a large macroprolactinoma. So patients who are male and patients who are female present differently with prolactinomas. Primarily, patients who are female present with smaller tumors than do the men. So this is a study which combined tumors with both different sizes, but you can see that the prevalence of macroadenoma was only 44% in the females and was 85% in the males. And the patients tend to be younger when they're diagnosed when they're female than males. And this may be because the syndrome of galactorrhea and amenorrhea brings women to medical attention quite quickly. On the other hand, the symptoms of hyperprolactinemia in men are much more subtle, including hypogonadism, low libido, erectile dysfunction, and breast enlargement. And these are things which are not as dramatic. And it may be then that the nature of the clinical symptomatology in men, which is more subtle, versus the amenorrhea galactorrhea syndrome in women, is the reason why women tend to present with smaller tumors. But there's a lot of evidence to say that that's not the whole story, and that there's a lot more differences in the growth potential of tumors in men than there are in women. So here you can see the variability in prolactinoma size. These are MRIs. Here's the optic chiasm. Here's a small microadenoma inside this pituitary gland. Here's a much bigger tumor, even extending somewhat into the cavernous sinus over here. And here's a big whopping neoplasm with marked extension up into the supracellular space. So all of these are prolactinomas, and it shows you that the growth potential and clinical biology of prolactinomas is highly variable. So the patient had headaches. So the reason for the headache is that when you have this expansion, you're stretching the dura, and that hurts. And this just shows a large number of patients and the types of headaches that you can have. And the bottom line is that you can have any kind of headache, really. So you don't want to say, oh, your headache isn't really consistent with a pituitary tumor because your headache's in the back of your head. So you can see that as many as 29 or 31% of people who have pituitary tumors have headaches in the back of their head. But the most typical headache is in the orbital region, behind the eye. It's usually on one side, and it's most often throbbing. But you can see that it can be anything. So I mentioned before that as the tumor grows, it starts to impinge, if it grows superiorly, it impinges on the optic chiasm. If it grows laterally, it can enter into the cavernous sinus where the third, fourth, fifth, and sixth nerves are found. So if the tumor starts to grow superiorly, then it can affect the optic chiasm by compression. And you remember that the bottom of the chiasm has fibers from the retina, which are from the superior fields. And then if you're a type of individual whose chiasm is right above the pituitary, then what's going to happen is that the pressure from the tumor on these inferior chiasmal neurons here are going to cause a superior quadrantenopsia. But many of us, when we were born, didn't exactly read the textbook, so that sometimes your chiasm is a little bit anterior, and sometimes your chiasm is a little posterior. So if the chiasm is anterior like this, and it presses here after the chiasm, then you can have a post-chiasmal type of field cut, which looks like a stroke, because it's going to be homonymous. Or on the other hand, if your chiasm is anterior, then you can be pressing on an optic nerve, and you can have a type of monocular blindness. And if you're sort of right in here somewhere, you can get what we had, and that is a type of field cut which affected one eye, but really not the other. So you can get all sorts of field cuts, just like you can get all sorts of headaches when you have a pituitary tumor. And this is 1,000 people, and it just says that you can have a bitemporal hemianopia, a superior temporal defect, you can be blind in one eye, you can have scotomatous, you can have homonymous hemianopsia, like I said, or of course you can have nothing, depending on how exactly the tumor grows in comparison. So you can have a big tumor with no defect. I mentioned that the patient had a low free T4, and it's to remind you that prolactin levels rise in hypothyroidism. They primarily rise in primary hypothyroidism, and the textbook explanation has to do with negative feedback and increased TRH, which produces TSH, as well as prolactin. But I think you can see that that's probably not totally accurate or completely accurate, because you can have hyperprolactinemia in mild hypothyroidism, and you can have it in rather more severe hypothyroidism. And in this study, the prevalence ranged from 22% in the milds to 36% in the overt. Overt means that the free T4 is low, as well as the TSH being elevated. In the mild, sometimes some people call that subclinical hypothyroidism. I favor the term mild because it's not really subclinical. The patients often have symptoms. But these are people who have a normal free T4 and have an elevated TSH. So you can see that hyperprolactinemia occurs in hypothyroidism. I also mentioned that she was tested for macroprolactin. You may be familiar with macro CPK. In the ICUs, sometimes you measure the CPK, and you probably know that sometimes we make antibodies to a variety of proteins, and that causes the protein to rise. And this is very well known for prolactin. So this is the regular prolactin here, 23,000 molecular weight. But we usually have a little bit of larger prolactin levels in our blood. This is a gel column, a chromatograph, where all of the fractions are measured for prolactin. And then you just compare it to the molecular weight standard. So most of the activity is here in a normal individual. But in an individual who is making an antibody to prolactin, then the individual prolactin level is a much larger molecular weight, and we usually use a little fancy test to precipitate large molecular weight peptides with a polyethylene glycol and measure the level before or after. And if it goes down a lot, That's probably macroprolactin. And it's really not that rare. It's maybe 5 or 10% of people will have macroprolactin. So you will find a high prolactin level in an individual who doesn't have a pituitary tumor and doesn't have headaches or visual complaints, and it can be very confusing sometimes. So patients with prolactinomas account for about 30 to 40% of all tumors. Among young women, most are small, but in men they tend to be larger. Interestingly, the microadenomas tend to remain microadenomas and rarely increase in size. At one time there was concern that taking oral contraceptives and using oral contraceptives when you have the diagnosis you shouldn't do, but this is probably not the case. Women frequently get galactorrhea because you need both estrogens and prolactin to get galactorrhea, and men rarely have the level of estrogen sufficient to do that. What prolactin does is it suppresses the GnRH pulse generator through receptors on neurons that make something called kisspeptin. And by turning off the GnRH, you result in hypogonadism. That's why the women have amenorrhea, and that's why the men have testosterone deficiency. And of course, an important consequence of hypogonadism is on bones, especially when it's long-standing. So you always want to review the DEXA scan of these patients to see if they're if they have osteoporosis. So unlike most pituitary tumors, the management of prolactinomas is medical, and it's with a dopamine agonist, most often cabergoline. Bromocriptine is an older dopamine agonist, which is administered on a daily basis, and this has a longer half-life and is administered usually twice a week, and it has fewer side effects. And even macroprolactinomas can be treated with these drugs, and we usually titrate the drug dose up, hoping to get the level less than 50, and within weeks to months after that, the tumor usually decreases in size. Some patients don't tolerate the drug. Sometimes it doesn't work, and some patients do have to have surgery. When you do have a macroprolactinoma, like I said, our patient probably did, you want to do formal visual field testing, look for other pituitary hormone deficiencies, of course do an MRI, and again treat the patient medically if it is a macroprolactinoma, and if that doesn't work, then they wind up with surgery. So the dopamine receptor agonists then decrease the prolactin mRNA. And that's why they lower the synthesis and the content and the secretion, and that's how the prolactin level comes down. But they also have an effect on cell growth and cause apoptosis of the cells, and together then these cause the tumor to be smaller in size. But there are side effects in some patients, as I mentioned before: nausea and dizziness, nasal congestion, fatigue, sedation, sometimes Raynaud's, and with very large doses, usually used in Parkinson's patients and not prolactinomas, you can get cardiac valve abnormalities. Okay, next case is a 43-year-old black female who came to the emergency room in 2012 with a severe headache and a history of temporal headache for several years. During the evaluation in the emergency room, she was found to have an aneurysm, and she had a coil inserted, at which time she suffered a stroke during the coil insertion. But at the time, the CT scan that they did also noted an enlarged cella, and was seen by our primary care folks, and she continued to have high blood pressure, and she wasn't really very good about taking her medicines, and she continued to have left-sided headaches, so that she had a CT scan and follow-up with that, an MRI, and in fact there was a 2-centimeter mass with supracellular extension. Now, I interviewed her subsequently, and in retrospect she told me that she had been snoring for several years, and the space between her top incisors had widened, and her hypertension was more difficult to control. And she denied hirsutism and increased sweating or enlargement of the hands and feet, and her menstrual periods couldn't be assessed because she'd had a hysterectomy. And she had high blood pressure, but no other major physical findings. But there were some subtle physical findings. You can see what I was talking about her incisors, how there's a space here. And you can see that her lips and jaw and maybe her frontal area of her bone of bones were a little bit more prominent than you might expect. So when she was first seen here, her cortisol was normal, her free T4 was borderline normal, the prolactin level was normal, estradiol was measured because you couldn't assess the gonadotropins because she had a hysterectomy. Her growth hormone was high. The IGF-1 was high. And which of the following then was the most appropriate step in the evaluation of this patient? Petrosal sinus sampling for growth hormone, measurement of growth hormone after a glucose tolerance test, referral to neurosurgery, the growth hormone releasing hormone arginine stimulation test, or measure of growth hormone after insulin-induced hypoglycemia. Not a lot of votes today, huh? Well, to me, it seemed like this lady had clinical acromegaly, and she had a elevated growth hormone and an elevated IGF-1 level, and she had a big old pituitary tumor. So to be honest with you, there really weren't any tests that I really needed to do. So I just referred her, when I heard about it, referred her for neurosurgery. Now, you can diagnose acromegaly by clinical features and by measuring the levels of IGF-1 and growth hormone, as was done here. So what they plot here are the standard deviation scores. Because there were several different assays used, they didn't plot the score directly. And you can see that among these 100 patients with acromegaly, many of them had values which were 10 times the average, and that the random growth hormone level was high, really, 9.8 nanograms per mil. And when they did a glucose tolerance test, the growth hormone level suppressed on average only to 4.01 with a wide range. And so here you can see from another paper that when you give glucose and measure the growth hormone, the value with our current assay should fall down to here somewhere, 0.1 or so nanograms per mil. Older textbooks will have much higher cutoffs because the assays continue to improve and they continue to reduce the baseline and the background noise in the assays, so that not too many years ago, if you read an article, it would say 2.5, and more recent articles would say 1, and now really we're down in the 0.1 range. But you can see that some of the patients really do suppress that low values, but it's pretty rare. So if the IGF-1 or the growth hormone levels are equivocal, or the clinical story is equivocal, or the clinical evaluation is equivocal, then certainly one can do a glucose tolerance test to get additional information. But in our case, everything sort of hung together, and the patient clearly had acromegaly, and I didn't think any additional tests were necessary. So we don't usually measure the growth hormone as the major diagnostic test because it's pulsatile. So if you were to measure an individual every couple of minutes, you would often find really very high values. It can be quite striking. And thus you might get a growth hormone level in a young female, which is 15 nanograms per mil, way above the usual upper limit of normal, which is maybe 5 or so. But you can see that if you would measure her another time, the values would be very low. This is more dramatic in young women than in young men because of the effect of estrogens on growth hormone production. And it's more common in young people than in older people because of the impact of aging on growth hormone secretion. Now, patients with acromegaly will present with a series of signs and symptoms, and the most common are growth of the hands and feet, deformity of the facial features, like we saw, and soft tissue swelling, increased sweating. Less commonly, they'll have headache. The males will have erectile dysfunction. There's an interesting acromegalic arthropathy, which affects the large joints. They can be fatigued. They can have tarsal and carpal tunnel syndromes, causing peripheral neuropathy and paresthesias. And some patients will have other symptoms, such as depression, reduced libido, daytime somnolence, weakness, hirsutism, shortness of breath, galactorrhea. This is sometimes due in association with sleep apnea. So the usual approach to the treatment of patients with acromegaly, very differently than prolactinomas, is to operate. And if you do operate and the tumor is small, you have a pretty good chance of curing the patient. On the other hand, the bigger the tumor, and is certainly the ones that are giant, they have a lower risk of cure, or likelihood of cure. This paper was from 2005. You can see how I told you about the baseline level, and their diagnosis of cure in 2005 was 2.5, very, very different than now. So our patient had a high IGF-1 and a high growth hormone. She had a borderline free T4, and the rest of these things were okay. She had surgery in September, and by January and again March, her IGF-1 level had fallen dramatically, and we are just watching her, hoping that she was among the people who had a big tumor who were cured. We'll find out. So the usual approach when people have pituitary tumors is to take the tumor out, usually transsphenoidally with an endoscope or a microscope, depending on the neurosurgeon's preference. And if that's not effective, we have three different approaches in our armamentarium. They including somatostatin receptor analogs. The most one with the longest track record is called octreotide. Another one is lanreotide, and the most recent one is called pasireotide. Another approach is a growth hormone receptor antagonist. That's called pegvisomant. And the third approach is pituitary irradiation. And among endocrinologists, you'll find a wide range of enthusiasm for all of these different approaches. Now, we don't want to leave the patient untreated if they have residual acromegaly, because excess growth hormone has a lot of negative long-term consequences. The patients have an increased risk for cardiovascular disease, perhaps because of diabetes mellitus or hypertension, or because of direct effects of growth hormone on the heart. They can have, I mentioned before, respiratory problems, mostly sleep apnea, arthritis, and increased risk for colon polyps and cancer. So this drug, pasireotide, is the most recent somatostatin analog, and it seems to be more potent than the other analogs, in part perhaps because it binds to a wide variety of somatostatin receptors, whereas the octreotide is a somatostatin receptor type 2. So I just shared with you this study. These were people who had surgery and then were being treated with one of the first generation analogs, octreotide or lanreotide, but they still weren't doing that well. And then they were randomized to remain on that in red, or to have 2 doses of the pasireotide, the lower dose in the green triangles and the higher dose in the blue squares. So here are the growth hormone levels in all the individuals. You can see that pretty much everyone responded a little bit, but there were a group of responders in whom the effect was quite dramatic, both on IGF-1 and on growth hormone. But you can still see that the IGF-1 levels at the end of the 24 weeks was still higher than the normal range, which would be below 300. But the trade-off for all these extra receptors is that there are such receptors in other organs, including the pancreas. So when you inhibit growth hormone with pasireotide, you also tend to have an effect on insulin secretion, and therefore the fasting glucose tends to go up, and the hemoglobin A1C goes up. So a side effect of using pasireotide is the development of diabetes. The next case. A 65-year-old man had been treated with testosterone for 5 years, but chose to stop treatment a few months ago. And he was sent in because of increasing fatigue and a brief dizzy spell with numbness in extremities. His BMI was 31, a little bit elevated, but otherwise his physical exam was relatively unrevealing. But the laboratory testing revealed low levels of testosterone and IGF-1. His FSH was high at 20.5, but his LH was on the low side at 2.4. And a CT scan of the head showed a 2-centimeter mass that appears to rise from the sella. So, how would you next manage this man? Refer him to a neurosurgeon, order an MRI, resume his testosterone treatment, perform a cortrosine stimulation test, begin octreotide. So after prolactinomas, the second most common type of pituitary tumor is either a null cell adenoma or a gonadotroph adenoma, both of which sort of present in the same way without any really clinical sequelae, because you can't be hypergonadal, really, and you can't have more menstrual periods than you're supposed to. So when these tumors make gonadotropins, really, what they do is disrupt normal ovulatory function or normal testosterone production. And of course, there are some tumors where if you do all the immunostains that are commonly done, there's nothing that stains, and those are called null cell adenomas. So between these two, 25 and 22%, nearly half of all pituitary tumors present in the same way as macroadenomas with no clinical hyperfunction and sometimes with hypofunction. This is especially true when people grow older. If you look in the patients beyond age 60, the majority have this greenish color here, which is a non-functional or gonadotroph producing macroadenoma. You can see that younger patients tend to have prolactinomas, acromegaly is across the board, as Cushing syndrome also is more common in younger individuals. So these gonadotroph adenomas are in a way clinically silent until they begin to expand the sella and cause headaches, visual complaints, and hypopituitarism. And they're characterized, just like in our patient, with an inappropriately high monotropic increase in FSH. And sometimes you'll also find subunits for alpha subunit and beta subunits. And because the LH is low, then the testosterone is low. And the treatment is surgery in these individuals, and if necessary with radiation. But what I was getting at in this individual was that he had clinical symptoms which led me to be suspicious of hypopituitarism. Remember the fatigue. So always think about hypopituitarism when you have someone with a big tumor. And hypopituitarism can present with weakness, nausea, weight loss, decrease in body hair, hyponatremia, hypoglycemia. And what I wanted you to do was perform a cortrosine stimulation test before referring him to the neurosurgeon, because you wouldn't want to conduct any surgery until you knew that the cortisol secretion was good, because if you were to send someone like that to general anesthesia, they might crash. So, you're probably familiar with the cortrosine stimulation test. The idea is it's an indirect but simple way to assess ACTH secretion and adrenal function. In a normal individual, the baseline morning values are somewhere between 10 and 25 micrograms per deciliter. So if you have a morning value which is more than 10, you're almost certainly going to be okay. But if you have a value below that, you might have a problem. So people with primary adrenal failure, you might recognize them because they're hyperkalemic, they're dehydrated, they are hyperpigmented, but you might be able to recognize them by the characteristics of this test, because if you inject ACTH or cortrosine, hardly anything's going to happen because they're already making a lot of ACTH. On the other hand, the patients with pituitary tumors are ACTH deficient, and if they've been ACTH deficient for a while, the enzymes that make cortisol in the adrenal gland are all downregulated. All those mRNAs are downregulated, and thus when you give the cortrosine, you get an attenuated increase. So the increased characteristics to be normal are usually a value of 20, an increase of more than 7 above the baseline. So you can see that this cartoon here, the values are way below that, and the increase is very small. So with patients who have large pituitary tumors which are non-functional or they're gonadotroph adenomas, you want to make sure it's not an aneurysm, which can be done by the radiologist. And you want to do this dynamic pituitary reserve testing, like I said before, to make sure that people are not cortisol deficient. You want to assess their vision by doing visual field testing, and then you're going to refer the patient to surgery after you've accomplished all of these things. Now, sometimes you'll find a little tiny pituitary tumor which seems to be non-functional, a microadenoma which doesn't make prolactin, growth hormone, or ACTH. And you really can just observe those people because many of the microadenomas just don't grow. And there's no reason to take out a small pituitary tumor unless it's functional, because it's rarely big enough to cause headaches. It's rarely big enough to interfere with vision. And thus it's probably just an incidentaloma doing absolutely nothing except causing you a lot of anguish. So the right answer in this case was to perform a cortrosine stimulation test before referring the patient to a neurosurgeon, at least in my opinion. Okay, so many patients like this man will present with hypopituitarism because they have a large pituitary tumor. It can also be because there's a tumor in the suprasellar space, like a craniopharyngioma. That can cause hypopituitarism. But there are some interesting other diseases, including autoimmune hypophysitis, hemorrhage into a pituitary tumor, which can occur at any time, and sometimes you get hemorrhage soon after pregnancy, and that's called Sheehan syndrome. Head trauma can cause hypopituitarism. I mentioned already that the carotid artery is right next to the pituitary, and an aneurysm of the carotid artery can cause hypopituitarism. And you can get a variety of infectious and granulomatous diseases, sarcoidosis, tuberculosis, abscesses, all causing hypopituitarism. And these patients can present with the symptoms of hypercortisolemia, like I said before, or they can present with symptoms of hypothyroidism. They can present with hypogonadism, with amenorrhea, decreased libido, and the most subtle thing they can have is a growth hormone deficiency, which in childhood, of course, causes children to have short stature if they have hypopituitarism. But adult growth hormone deficiency is quite a vague clinical disorder with increased fat mass, decreased muscle mass and strength, and decreased exercise capacity, and low bone mass. So among the interesting disorders causing an enlarged pituitary, which are not tumors, are lymphocytic hypophysitis, which is an autoimmune type of disease, and is sometimes seen together with other autoimmune diseases, most notably lymphocytic thyroiditis or Hashimoto's thyroiditis. And like most autoimmune diseases, it's much more common in women than in men. And we see it sometimes in pregnancy and in the postpartum period. 2 weeks ago, the endocrine consult service saw a lady on the gynecology service. She's pregnant, and she presented with a headache at the end of her pregnancy, and she had some evidence for hemorrhage and an enlarged pituitary, slightly enlarged, but no story about having any sort of endocrine disruption before the pregnancy, and I assume, but don't know for sure, that she bled into hypophysitis. Consequently, the presentation is often headaches. Sometimes these pituitaries grow so much that they can look like a tumor and cause a visual disturbance. Sometimes they involve the pituitary stalk and cause diabetes insipidus, and of course hypopituitarism. And it's very tricky as to decide what to do with these patients, because sometimes the hypophysitis regresses, and sometimes you feel compelled to send them for surgery if they have headaches or visual field defects. This is a very sophisticated and difficult decision. Sheehan syndrome is an enlarged pituitary during pregnancy which bleeds. And you could see that there's really a lot of overlap between the concept of autoimmune hypophysitis and Sheehan syndrome. And many people think that Sheehan syndrome was just bleeding into autoimmune hypophysitis during pregnancy. But it's worse because the pituitary grows during the pregnancy under spontaneous conditions and may exceed its blood supply. And this type of disorder, where you get a vascular collapse in the postpartum period because of the profound ACTH and cortisol deficiency, is really less common here currently, but there's still cases reported, and it's recognized in the developing world. And how might you know this woman has that? Well, the vascular collapse that I told you about. But if it's more subtle, you might have a woman who is trying to breastfeed and can't, or a woman whose menstrual periods don't recover after she was pregnant. And these symptoms may be so subtle that they may not occur really for many years after the event. And if you follow many of these patients, both with autoimmune hypophysitis and Sheehan syndrome, sometimes the long-term sequelae is what's called an empty sella. Now, sometimes patients with pituitary tumors will present abruptly with a severe headache. Sometimes it's called a thunderclap headache. This has been the worst headache ever in your life. And what's going to happen then is that the tumor can bleed. And if it bleeds and it bleeds into the cavernous sinus, then you begin to put pressure on the third nerve, and you get this third nerve palsy. So you can see there's an abducted eye. You can see that he's got ptosis, and he's got extraocular movement problems. And this is pituitary hemorrhage. And here you can see it on the MRI right here. So this is a sudden severe headache in a pituitary tumor with a visual disturbance, sometimes with increase in intracranial pressure, causing a decrease in mental statics. And the syndrome is called pituitary apoplexy. The bleeding is called hemorrhage. You don't have to have apoplexy if you have hemorrhage, depending on how extensive it is. A small hemorrhage like this one, without any suprasellar extension, may have just been a very severe headache. I don't think you'd call that apoplexy. And it tends to occur into pituitary tumors. I told you about pregnancy and Sheehan syndrome, and it occurs in people who are anticoagulated. And again, there's controversies as to when to do surgery in people with pituitary hemorrhage, because often they'll just slowly resolve, and maybe surgery can be postponed instead of doing a immediate operation, and the surgery can postpone until you figure out what's the diagnosis and whether there's any endocrine disturbances, and you can get the patient in better shape for surgery. Now, when you have a pituitary mass, I already alluded to the fact that you can have other things, lymphocytic hypophysitis. You can have things like sarcoid and Wegener's, and it could be a cyst, tuberculosis, histiocytosis, primary tumors such as lymphoma, or metastatic tumors. So people who present with hypopituitarism often are wonderful cases for rounds because there are a lot of physical findings and historical points that you can begin to elucidate so that you're sure that the patient doesn't just have a pituitary tumor, but perhaps has something quite unusual. So, of course, patients who have hypopituitarism needs treatment. They can be treated with glucocorticoids, either hydrocortisone or prednisone, usually in twice daily doses. They, of course, can be treated with thyroxine to replace the thyroid hormones. When they are younger, they'll be treated with gonadotroph, estrogens and progesterones in women, and androgens in males. Patients who have hypopituitarism are not infertile. They can be treated with exogenous gonadotropins to stimulate the gonads, both the testis and ovary, and they can also be treated with growth hormone to treat that elusive growth hormone deficiency syndrome, which I mentioned. So I think we're running out of time, so we'll take a couple of questions or comments, please. Thank you very much.